It's my privilege and to introduce Dr. Rahul Pandit sir. Rahul Pandit sir today is giving a talk on ECMO in cardiogenic shock. Way to go. He is one of the renowned intensivists in India, and he trained well-structured critical care thing in Australia. He is currently chairman of critical care and emergency in Christian Reliance Foundation Hospital, or Reliance Initiative. And apart from that, he is visiting consultant for ICU in Australia, and is also member of National Task Force, which is appointed by the Supreme Court, and is also chairman for the daily ICU and even medicine, and is currently a teacher of DRNB and College of Intensive Care Medicine in Australia. And under his name, so many publications and so many chapters he wrote, and his special interest in critical care echocardiography, ultrasound, brain trauma, and organ donation. With these kind words, I request Sir Dr. Rahul Pandit sir to go ahead.
Good morning and thank you very much, the Reflect team, for inviting me to this beautiful city. Over the next, how much time do I have? 15 minutes or so? 20 minutes. 15 minutes. I'm going to talk about ECMO and cardiogenic shock. Is ECMO the way to go in cardiogenic shock? So I'm going to sort of talk about first the definition of cardiogenic shock. There has been some evolution of definition of cardiogenic shock over the last few years. We'll talk about the guidelines state. Then we'll talk about the real world evidence, which is the trials which have come out and what they talk about. And then I will show you some data from my unit. So let's start with the case. This is a gentleman who is just nearing 60s who comes in with 2 hours of feeling unwell, has got background of hypertension, diabetes, chest discomfort, already hypotensive with a blood pressure of 80/50, and he's got bilateral palpitation from auscultation, ECG showing a myocardial damage, and now he becomes more hypotensive and drowsy, blood pressure drops down. Your plan of action obviously would involve number of interventions. We could start off with inotropes, vasopressors, recanalization, revascularization, IABP. Still, if you are struggling, then the question comes that this person is going to cardiogenic shock. So where are you going to think of ECMO? Are you going to think of ECMO when you finish all of this and then think of mechanical cardiac support? Or are you going to think of ECMO right here, along with your noradrenaline and adrenaline? Or there is no role for ECMO at all in this condition. So let's try and see all the scenarios. I'm not going to discuss the case as such in detail, but we will try and cover up these scenarios in detail. So if you look at the simplistic definition of cardiogenic shock, we know that it's one of the leading causes of mortality, and around 40 to 60% of the patients who have cardiogenic shock will die in the hospital. And around 15%, 10 to 15% of patients who develop myocardial infarction, who have a myocardial infarction, will develop a cardiogenic shock. And unfortunately, females are at a higher risk than males who develop cardiogenic shock. If I look at a simplistic definition which has been going on for a long time, you would say that when there is systemic hypoperfusion, secondary to a severe or depressed cardiac output, with or without sustained arterial hypotension, despite elevated filling pressures, you would call that condition the cardiogenic shock. And if you look at the age-old numbers, true until around 2016, which is around 7-8 years ago, you would see the standard numbers. If you look at it, blood pressure less than 90 systolic and organ perfusion by way of lactate, perhaps cold extremity, liver output dropping down, heart rate more than 60, and then if you go a bit deeper, your cardiac index goes down and the pulmonary capillary pressure is showing good filling pressures there. Okay. However, this definition really did not take us into a lot of understanding of when do we go and think about mechanical cardiac support. And this definition, which has been going on for the last 15-20 years, needed some evolution. So this society, the Cardiovascular Angiographic Intervention Society, also calling as SCAI, came up with a classification. They published it around 3 years ago, 2022, I think this publication is, 2 years ago. And the publication essentially looks at having a 3-axis model of identifying cardiogenic shock. So first of all, they look at the phenotype. Is it acute? Is it chronic? Is it having clinical etiology? which is consistent with cardiogenic shock? Is it because of the right ventricle, left ventricle, or biventricle, so on and so forth? Then it looks at the severity, which is based mainly on the shock staging which they have done, hemodynamics, metabolic derangement, and then what are the risk modifiers which are there. For example, maybe comorbidities, age, was there a cardiac arrest when the patient came in, was there coma? Based on that, this classification has been now made up of pyramidal structure. Fortunately, majority of the patients who have propensity to go for cardiogenic shock or who have developed some evidence of clinical hemodynamic instability form the bottom part of the pyramid. So there are a large number of patients. As we go up, as we know, only a few of them will actually go on to develop a deteriorating or extreme kind of shock. And right now what we classify based on this classification is those who are in class E, B or class E are the ones who are probably going to benefit the most from mechanical cardiac support. This is what basically the evidence has been trying to tell. However, there is still a little bit of understanding which we need to probably prove with more trials, that should we be intervening when it is already a classic cardiogenic shock. So what we are talking about is you have cardiogenic shock and then we are looking at refractiveness of that. Whether it's going to be refractive and then you are going to use that as the starting point for mechanical cardiac support, we probably don't know that. Okay. So let's go and look a little bit into detail about what the guidelines say. Now the guidelines, the ELSO guidelines, which are the biggest guidelines, which look at all the data, maintain the registry, have really modified the indications which cardiogenic shock is caused by. So the ones who are in black gray are acceptable indications to go on for a mechanical cardiac support. However, the ones who are in light gray have got emerging indications as a title. So we can sort of think of a trauma, a drug intoxication. You will have to see case to case. But these ones really have got important understanding that they are probably really the indications to go on for mechanical cardiac support. Now, the same registry, the same guidelines talks about indications but does not talk in detail about contraindications. What they say is that you go to the SAVE score. Now this SAVE score is a scoring system which looks at variety of things, right from demographics to your clinical condition to your comorbidities as well as the intervention which you are doing, for example peak airway pressure, diastolic pressure, all those things. And you can have a scoring based on either positive side or negative side, can go from -35 to 17. Needless to say, if you are scoring on a positive side, your outcome is good. As you start going down, your outcome becomes very, very poor. Now this survival and this outcome-based score has not really been studied into any trial. This is just a very big dogma of clinically clear signs and symptoms which are associated with poor outcome. So there is no real trial where the SAVE trial, actually SAVE score was tried out. But when they are putting it into the registry retrospectively, they are understanding that a score of more than 5 has got a better outcome versus a score of less than 5. So this is what basically the problem is, that it's not really evidence based, it is more of an eminence based. It's a categorization of symptoms which are based on clinical outputs and dogmas which we carry with ourselves. But if you look at the registry data, this is the last year's, I have downloaded it for the last year 2022. This is the latest one which I could get. If you see, this is the one which I want to point out. Adult cardiac, around 49,000 patients, survived 29,000. So surviving ECMO was 60%, but you further drop it down by another 14%, you have a survival of only 46%. That means 54% died. And this is the registry, and you can see number of people who are now contributing to the registry are increasing year by year. So there is significant amount of contribution happening from across the world. And if I just look at this one abstract which was submitted in ISCC a few years ago, look at the number of centers which are doing VA in India. This may be just the tip of the iceberg, and we will be missing out a lot of centers as well. That brings us now to the current real life evidence, really what is happening. So this is I start with the review article. This was a review article published a year and a half ago by Claudia, and they talked about VA ECMO, central as well as peripheral, and reasonable indications. Again, cardiogenic shock, refractory to conventional medication, and device-based therapy. Device-based therapy was essentially limited to IID patient, nothing else. And then you have this indication where you want to put them on. What was interesting is that this is the only one clear contraindication list which is published by any review article. The ELSO also does not give a very clear contraindication list that where you don't do it. So, disease unlikely to recover, panic when see neurologic injury, pre-existing complications, conditions which may be incompatible with ECMO. And then there are some relative indications. Age is one of them, medical comorbidities, poor compliance, which you will have to sort of look at day-to-day basis. Then if you move to the trials, this is the latest trial published last year, late last year, which is the EuroShock trial. Now EuroShock trial was supposed to answer the question that VA ECMO in patients with cardiogenic shock, complicated due to acute myocardial infarction, what are the outcomes? Very well designed trial, was designed to have around 15 centers across 6 countries in Europe and was aiming to recruit around 428 patients to demonstrate around 28-29% reduction in the primary endpoint in death from all-cause mortality, and it was sort of reasonably powered as well. And they were going to follow up for a 30-day mortality and have a 50% reduction from the mortality in the standard therapy arm. Unfortunately, COVID stuck. When COVID came in, look what happened. For them to randomize 15 centers to only randomize 35 patients. 428 was the target. They could only randomize 35 patients in 4 years and they came out with these numbers. So standard therapy 18, VA was 17, and then if you go and look at further deep dive into that, because the numbers were slow, obviously the all-cause mortality was higher in standard therapy versus VA chemotherapy, but major bleeding was a little bit higher in the VA chemotherapy, and failure to discharge from primary admission again was significantly different. However, with 35 and the study grossly being underpowered, they could not make any recommendations, neither the statistical significance was actually proven. So this study essentially has been published to show how a good well-planned study can completely go off because of some unnatural or unanticipated problems which we faced in the world over the last 3-4 years. So that's what they say essentially, that they could not conclude anything. Then simultaneously in the same month, a month prior before this EuroShock came in, a meta-analysis was published. A meta-analysis looked at around 32 trials. They did a funnel plot, and the funnel plot they looked at the type of the study, and they saw that we will have to take up a variation of the standard. So anything which was basically around 1.5% of the standard error on the margins, they included these blue dots which are the studies in their analysis. They excluded the ones which are on the white side out there. So they excluded around 16 studies which were out there. What did they find when they pulled the data? The overall pooled in hospital mortality was 61% for VA ECMO patients, and an average age of around 60 was found to be associated with poor outcome. Obviously, shorter the ECMO, poorer was the outcome, needless to say, and the presence of infection along with a cardiac problem was associated with the high in-hospital mortality. This brings us to the latest trial, the second trial, sorry, not the latest trial, the one which was published around 2022 is the cardiogenic shock ECMO trial or the ECMO CS trial. Now the ECMO CS trial essentially was looking at extracorporeal membrane oxygenation in therapy for cardiogenic shock. Now it had a very interesting design. The design was, they had two groups. One group was looking at immediate ECMO, other group was looking at not so immediate ECMO. And the endpoint was death from any cause or resuscitated circulatory arrest and implementation of another mechanical circulatory device at 30 days. Okay. Now they could randomize around 122 patients, of which 5 were excluded because of lack of consent, 117 equal in both arms, and the composite primary endpoint did not unfortunately differ, 37% versus 72, 40, 37 versus 42, which was 63% versus 71%, not statistically different. The Kaplan-Meier curves were actually matching each other right from day one, and essentially there was no difference in the outcome whether you initiated ECMO early or late, and this was one of the big things. Now if you deep dive into the data, you could see that this bold red line on both sides, which actually says conservative with rapidly deteriorating cardiogenic shock. Conservative with rapidly deteriorating cardiogenic shock. Not severe, but rapidly deteriorating. If you actually just continue with your conservative therapy there, you may have lesser mortality. So really don't need to go and put those patients on ECMO at all. You may just continue. The problem was with the ones who went on to become severe. In that case, you will have to think of ECMO as a possibility. But if they are actually improving with your current therapy, just stick on to it. So what did they interpret? They said early ECMO does not improve the clinical outcome, and if you can continue with the early conservative strategy, continue with that. Don't worry about it. Okay. Last couple of slides and I will be done. Association between extracorporeal membrane oxygenated timing. Now this is a Korean study, which is the odd kid out of the block. Everybody said don't initiate early, all the 3 trials as well as the meta-analysis. Here they are saying to initiate it early. If you initiate it within the first 2 hours, you would actually have a better outcome. So this is the only odd one, but low numbers, not very high numbers. Same group then went and looked at their own patients in this. Obviously it was not powered to look into this. But they saw the patients who had cardiogenic shock as well as proven sepsis. And when they have sepsis, the outcome was extremely poor. So the survival for sepsis and refractory shock put on ECMO was only 7%. So if you have sepsis with cardiogenic shock, the outcome is visible. Please don't do anything for these patients. This is an old study looking at children. And unfortunately, the data in children is very, very good for myocarditis. So if the children have myocarditis, go ahead and put them on ECMO, VA ECMO. Majority of them will reverse back and will actually improve. However, same cannot be said true for adults. Adults have a very poor understanding of the data. So ECMO is like a parachute. If you open it too early, you are going to have complications because you are actually at a very high altitude, which the air is not sufficient to support your parachute. If you open it just right, you will have a good landing. If you leave it too late, obviously the patient is going to die. Now this is from the AHA cardiogenic shock, ECMO shock trial. I'll talk to you about my data. This is my last slide. Last year we did around 27 ECMOs, of which 13 were VA, 14 were VB. 4 ECMOs were bridged to a heart transplant. 2 of them got heart. 2 of them died waiting for a heart. We could not get a heart for them, but they were also too sick. I mean, they died within 48 to 96 hours of being in the hospital. 7 were used as a rescue from either post-cardiogenic shock or post-CABG or valve surgery. So post-cardiac surgery or cardiogenic shock. 1 survived in each of the group. That's it. We lost the other patients. ECPR was attempted in 3 of them. 2 died within the first 6 to 8 hours because we could initiate ECPR, we could start the cannulation as well as the circulation, but there was no return of spontaneous circulation. 1 who survived well and went home well. So we had a reasonable amount of plasma outcome scale. So essentially the ECMO team must resist the temptation to act first and think later, but rather govern the use of ECMO in a way that not only honors life but also honors death. So my friends, I would like to conclude that ECMO is now more and more frequently used in cardiogenic shock, but certainly I can't say that it is the only way to go forward. I would still put emphasis that if your patient is improving or is stabilizing on your conventional therapy, do not think of putting them on ECMO. But if you leave it too late, then unfortunately you are going to have a patient who will die. Indications have broadened, timing is important, and you should have the ability to say no, because quite often we take emotional decisions based on patient's age and the surrounding factors and end up with a patient who does not survive. Thank you.
Thank you, sir. We covered entire thing of